we'd like to introduce our next speaker, who is Dr. Deanne Lacaille. She is professor in the Division of Rheumatology at the University of British Columbia and a senior research scientist at Arthritis Research Canada. Her research focuses on two areas. One, studying the impact of arthritis on employment and preventing work disability. And two, evaluating the quality of healthcare services received by people with rheumatoid arthritis, using a population-based cohort of rheumatoid arthritis for the province of BC. Her topic today is good news about the lifespan for people with rheumatoid arthritis. Deanne?
Good morning. Thank you to APAB for the opportunity to share my results and be able to share good news for people living with rheumatoid arthritis. And so the overview of my talk, I'm going to show you how past studies showed that people with rheumatoid arthritis died earlier than people from the general population of the same age and sex. That's obviously not the good news. But the good news is that more recent studies have shown that the mortality has improved and that this problem is not like it used to be. We assume that this is because we have more effective treatment for rheumatoid arthritis, and I'm going to show you some results from our studies showing that medications to treat RA have a beneficial effect on the risk of mortality. So there has been a number of studies since the first one published in 1950 that looked at this question of mortality in rheumatoid arthritis, and most of the studies found that people with RA were at risk of dying at an earlier age than people of the same age and sex from the general population. And if we pool the results from all of those studies together, we find that the risk of death is increased twofold in people with rheumatoid arthritis. The exception to this is there were some studies of early rheumatoid arthritis where patients were treated very aggressively to eliminate inflammation that reported no excess mortality. And you may wonder by how much was the lifespan reduced, and a study addressed this using life table analyses from Australia found that the lifespan was reduced by 8 years in men and 9 years in women. And I want to show you this graph that illustrates this quite well. This is Canadian data from Saskatchewan that was published in 1994. So it followed men and women with rheumatoid arthritis in the 70s and the 80s. And this is survival. So at the beginning of the study, everybody is alive. Over time, as people die, survival is decreased. The best survival is for women from the general population, this top curve. And women with rheumatoid arthritis, if you follow the blue arrow down, you get to the curve of women with rheumatoid arthritis, and you can see that their survival is decreased. We see a similar effect in men from the curve, from the men from the general population here. If you follow the red arrow, you see that men from the rheumatoid arthritis have a lower survival. And this is what we call the survival gap between RA and the general population. You might wonder, what are people dying of? And it's cardiovascular diseases, so things like heart attacks and strokes, that are the leading cause of increased mortality, and they're responsible for a third to a half of the excess deaths in RA, and for reductions in life expectancy in the range of 5 to 10 years. Other causes include infections, and studies range in that risk of a 5 to about 10-fold increase in risk of infections. Also lung disease, either the lung disease from rheumatoid arthritis itself, but also increased risk from pneumonia, and also from chronic obstructive pulmonary diseases, or COPD. And we actually just had a study of ours released this year, so it's hot off the press, showing that the risk of COPD is increased in RA compared to the general population. There's renal disease is also responsible. And finally, people often wonder about cancer. And in general, when we look at all cancers, the risk is not increased. but for lymphoma and lung cancer, it is increased in RA. Now, you may wonder, when someone has RA, what are their risk factors? And we see that people who have more active and more severe disease, so things like more joints that are swollen and painful, greater level of pain, or the markers in the blood work of inflammation like the Steroid or the CRP, people who have poorer physical function, the antibodies of rheumatoid arthritis that are a marker of more severe arthritis, so rheumatoid factor and anti-CCP, and finally extra-articular features. That means when arthritis affects other organs in the body, like the lungs or the heart, that increases the risk of death, and as well as longer RA duration. The other risk factors are the same as in the general population, so older people, men, people with less education, lower socioeconomic status, smoking, body mass index, and having other chronic conditions. So you can see that some of these risk factors are modifiable by lifestyle, like smoking and body mass index. And this brings me to the question that was of interest to me, and that was that with the major advances that we have seen in the treatment of rheumatoid arthritis in the last 20 years, with more effective medications, including but not limited to biologics, but more so with the complete change in how we treat RA, where we really aim to completely eliminate inflammation by using disease-modifying agents early and aggressively. And this new treatment strategies have shown that we have better, longer outcomes for the joints. So the question is, has this translated into improved mortality? So we set up to answer that question with a study where we compared mortality in RA to that in the general population over time by comparing the mortality risk in RA patients that were diagnosed between 1996 and 2000 and compare them with people who were diagnosed after 2000, so from 2000 to 2006. We selected 2000 as a cutoff, not just because it's the new millennium and it sort of seems like a good number to cut off, but that's when biologics were introduced, and that's also when this shift in treatment aiming at remission and low disease activity really took on. So we looked at everybody in RA in the province of British Columbia, and to do that we have data from an administrative health databases that have been provided to us from the Ministry of Health. I want you to rest assured we have no identifying information, so we can't tell who's who, but we just have kind of all this data pooled together with no identifiers. And we selected controls from the general population who didn't have arthritis, and we matched them in terms of age and gender and calendar year. And then we divided the cohorts into those people with RA diagnosed in 96 to 2000, the earlier cohort and their controls, and those diagnosed after. And we looked at their survival over the first 5 years of the disease. And what we found was that in the earlier cohort, people with RA had a 40% increased risk of death, so that's the hazard ratio of 1.4. But in the later cohort, for people diagnosed after 2000, there was no increased risk. The hazard ratio was essentially 1, which means equal. I think it's easier to actually see this with this graph, which shows the survival. Here is the people with the onset before 2000, and you can see that survival of people with RA is lower than that of the general population. But for people diagnosed after RA, those two curves are essentially identical. So we did not observe the increased risk of death in RA compared to the general population. You might argue that by 8 years, maybe it's starting to separate. We also have a lot less numbers at that time. So in conclusion, in our study of the people with rheumatoid arthritis in BC, we see that the risk of death has clearly improved over time. Over the first 5 years of disease, the reduced survival observed in people with RA onset before 2000 was not observed in people with RA onset after 2000. But I do want to caution us before concluding that mortality difference no longer exists, that we need studies with longer follow-up than 5 years. This brings me to my second topic, which is what is the effect of RA medications on the risk of mortality? So since inflammation and disease activity are responsible for the increased risk of death, if RA medications are effective at reducing inflammation and improving disease activity, we would expect medications to improve mortality as well. However, potential side effects of medication could also increase the risk of death. And the best data is really for methotrexate. And it has clearly been shown in a number of studies, and the first one was by Dr. Hyun Choi, also an ARC scientist, published in 2002, showing that use of methotrexate reduced the risk of death from any cause by 60%, and was particularly an effect on risk of death from heart disease, where it reduced the risk by 70%. We did a study in BC where we were interested in the effect of biologic treatment. So same database that I already talked to you about. We looked at everybody who'd received an anti-TNF agent. At the time, that was the type of biologic that had been more commonly used. We selected controls. We wanted people that were somewhat similar, so pick people who had been on at least 3 disease-modifying agents and had recently started a new medication, and we matched them on age and gender, calendar year, and other factors that might influence the likelihood of receiving an anti-TNF agent. And what we found was that people who used an anti-TNF agent had a 50% lower risk of death than people who did not. We found a similar effect of methotrexate, which was a 55% lower risk of death, similar to what Dr. Choi had found before. In contrast, we found that prednisone was associated with a 2.5 higher risk of death, and I'll have more on prednisone and corticosteroids. And we found no difference for the use of anti-inflammatory medications. And the rest are the same general risk factors like gender, age, and comorbidities. So this brings me to the last medication I want to talk about, and these are steroids. The most commonly recognized medication that you would have heard of is prednisone. And we looked at oral prednisone, so this does not include injections of steroids into people's joints. And we studied everyone with new onset of RA from the time of their onset of RA to their end of the study or to death, and we looked at the use of prednisone. And what we found was that when people were using prednisone, their risk of death was increased by 73%. We found also that the dose mattered. So for every 5 milligram increase in the risk in dose, there was an increase in risk of death of 22%. And we found that the longer people used it, it also mattered. For every year of prior use, the risk of death increased by 30%. So there's some concern about prednisone use. The question that I'm often asked is, okay, but I'm using just a very small dose of prednisone. And is there a safe dose of prednisone? And that's what I wanted to show you with this graph, which is looking at the risk of death from either all causes. They compared different doses of prednisone, and what it shows is that at doses of 5 or 7.5 milligrams, the risk, at doses of 5, the risk is around 1, so it doesn't seem to be increased. At 7.5, it's a little bit above 1, but there's uncertainty around this risk, and the uncertainty of the risk crosses 1, so we're not sure if 7.5 increases the risk or not. But anything above that, the points are way above the horizontal line of 1. So if sort of the risk here is 1, the 5 and 7.5 were kind of just there, and their confidence crossed 1, but the other ones were clearly above. So in conclusion, so the summary from what I've told you today is that rheumatoid arthritis has been associated with increased mortality up to 2-fold, especially from heart disease. This increased risk of mortality has improved in recent years. Methotrexate use is associated with a reduced risk of death, especially from heart disease. Exposure to biologic agents, such as anti-TNFs, is associated with a lower risk of death, but prednisone use is associated with an increased risk of death with a safe dose threshold of 5 or 7.5 milligrams per day. I want to acknowledge my co-investigators, including the patient partners on my studies, the Ministry of Health for the use of administrative data, CIHR for funding the projects I talked about, and UBC and the Arthritis Society for the chair that I hold. Thank you for your attention. Currently, I have time for one question. Okay, and I'll put it up there you go. That was sort of what I tried to illustrate. So you can, these are the 5 and 7.5. I mean, the different models are different analyses, but if you look at the first two in the groupings, this is from heart disease and this is from all cause, and you can see the other doses are clearly higher. Yes?
Dose to 5 milligrams, how effective is it? Is it still effective?
Is it still effective? So often for rheumatoid arthritis, and it's different for other diseases, but often in rheumatoid arthritis, people are very sensitive to the effect of prednisone. And there are some patients that at 5 milligrams, it makes a difference. And if people stop it, it makes a difference. So it seems that 5 milligrams, it can be a dose that's effective for people. But I think the big question is, if people are using prednisone, the first attempt would be to see, can you get a better control of the disease by using disease-modifying agent and using other medications? And that if you use prednisone, we try to use it for time-limited periods until those other medications are kicking in and are being effective, or for short periods when you're having a flare-up of your disease. The concern is the people who are on especially higher doses for long periods of time.
Thank you.